good setting.
अभी तो हमारे पास पैसे नहीं है, अदरवाइज वो सबके सामने है अभी. इफ यू गो टू किंग एडवर्ड, उन्होंने तो सबके सामने ना वो स्क्रीन्स भी आ गई नहीं.
Bismillahirrahmanirrahim. Inna atayna kal kausar fasalli li rabbika wanhar inna shani'aka huwal abtar. Honorable speakers and dear participants, very warm welcome to this webinar, which has been organized by Punjab Healthcare Commission on a very important patient safety issue, which is management of medication and ensuring medication safety. My name is Dr. Mushtaq Slaria, and I'll be moderating this event. We are honored to have distinguished speakers amongst us today who will be talking about different aspects and different topics on the medication safety. We are lucky to have Dr. Muhammad Saqib Aziz Saab, he's CEO of Punjab Healthcare Commission. We'll be joined online by Professor Khalid Masood Gondal, who's an incumbent President CPSP and VC Fatima Jinnah Medical University. We will also be joined by Professor Masood Sadiq, who's VC University of Child Health Sciences. In this conference room, we have with us Dr. Haroon Hafiz. He's Director Quality and Patient Safety at Shaukat Khan Memorial Hospital. To his right is Dr. Ziaul Hasnan. He's Additional Director, DRAP, and in charge of the Punjab DRAP office. To my left is Dr. Asim Rauf. He's former CEO of Drug Regulatory Authority of Pakistan. And with us also Dr. Humar Rashid, who's a pharmaceutical expert and is the Additional Director Monitoring and Evaluation Quality Assurance at Punjab Healthcare Commission. Thank you very much, sir. Thank you, the honorable panelists, for joining, or thank you, participants, for being with us. Participants, medication safety is an important patient safety issue, while the management of medication itself is a complex and multi-stage discipline. It involves 4 basic domains, including pharmaceuticals, professionals, healthcare service providers, patients and public itself, and regulatory systems and regulatory and monitoring systems. It is with this background that we have invited, requested participants and speakers from regulatory, healthcare regulatory organizations like CEO Punjab Healthcare Commission, from quality and patient safety and clinical experts, Dr. Harun Hafiz, or similarly academicians and educationists, medical educationists, Professor Khalid Masood Gondal and Professor Sadiq from VC University of Child Health Sciences, Dr. Masood Sadiq. Similarly, we have also requested our experts from Drug Regulatory Pakistan, Drug Regulatory Authority Pakistan, Dr. Asim Rao Sahab, Dr. Zia Hasnain Sahab, or our expert in pharmaceuticals, Dr. Huma Rashid, to talk in this important subject. Being a global patient safety challenge, WHO every year observes Patient Safety Week, and this is the 10th week being observed by WHO, the first being observed in 2016. This is always every year observed in November. This year it is from 3rd to 9th November. So the theme this year for this topic for patient safety is we can all help make medication safe. The Punjab Healthcare Commission has organized this webinar to highlight importance of medication safety with the objective to support healthcare service providers in their effort to eliminate preventable harm to the patients due to medication errors, and also to promote a culture of reporting with no blame culture. The key speakers will discuss various aspects of making medication safe. They will talk about the regulatory insight in respect of the healthcare establishments for ensuring medication safety, medication-related adverse events, medication safety and special consideration in pediatric age patients, and role of communication failures in medication errors, and similarly human factor in medication errors, and ultimately role of DRAP in pharmacovigilance for ensuring medication safety. Dear participant, before we proceed further with our proceedings and talk, I request the speakers for their presentation. Let me inform you that we will be taking your questions in the chat box. And at the end of the webinar, at the end of the session, we'll present it to the speakers for responding accordingly. I would now invite the first honorable speaker, Dr. Mohammad Saqib Aziz Saab. He is Chief Executive Officer, Punjab Healthcare Commission. Dr. Saqib Aziz is a former civil servant with a career spanning over 35 years, and he has worked as a policy formulation and implementation position as Federal Secretary and Deputy Commissioner and Commissioner at various districts and divisions. He's leading Punjab Healthcare Commission since 2021 as Chief Executive Officer. He will basically present an insight of the regulator into medication safety. And after his opening remarks, we'll hand over the presentation to Dr. Huma Rashid, who will further elaborate on the latest regulatory interventions in terms of improving patient safety through medication safety. So over to Dr. Saqib Aziz Saab for his opening talk and for discussion.
Aji, thank you very much. I welcome all the distinguished participants who are here at the Punjab Healthcare Commission building, as well as our distinguished guests who have joined us online, Professor Masood Gondal Saab and Professor Masood Khalid Saab, Masood Sadiq Saab, VCs, as well as I also welcome all those participants who are with us online. As you know, today's topic is basically how we can make our patients safe and what are the mechanism of steps in making the medicine more safe for patients. Before I proceed further, let's say what is the international scenario and what is the scenario in Pakistan. So let's no need of any presentation. Basically, if we see the global figures and global data, we come to know that as per WHO reports, different reports, and I'm quoting WHO report 2022, that the medication errors and adverse drug reactions, they cause harm one person in every 20 patients. Out of 421 million cases which are hospitalized each year, 42.7 million face adverse events globally. In the USA, only around 2 million cases of ADRs were reported during last year, despite spending billions of dollars. And in USA and other countries, it is the third leading cause of death. And the interesting thing is that I would say that more than 50% of these medical errors or ADRs are preventable. This is the WHO report says. Out of these ADRs, the medication errors, which constitute, which relate to wrong dose or wrong route or wrong patient, they constitute around 18.3% of medical errors. So this is the global scenario, which basically lays emphasis and also shows up the gravity of this challenge all over the world. Now let's see the scenario in Pakistan, that what is the situation in Pakistan. Basically, I'm trying to build up the context in which we work and the context in which our doctors operate and other stakeholders. Pakistan is a country having more than 125 million population, overpopulated, I would say, out of which, as per official figures, the literacy rate is only 60%. And the level of awareness, I would say, is very weak, especially people awareness towards medical awareness is negligible. They don't know. Everybody who works in a hospital or clinic, and if he or she wears a white coat, people call him or her Dr. Saab. Even we come across many cases in which people who are working on clerical jobs, but in some health facility, they have also opened their clinics or quackery outlets, and they are also considered and recognized as doctors in our country. We have a weak regulatory and enforcement mechanism. And also there is a robust culture of self-medication. I think hardly I see a person who is not involved in self-medication, and we very freely, and I think we consider it our duty to not only exercise, carry out this practice on ourselves, but very freely we also lend our advice to other people. So this is, I mean, very rampant, and this culture of self-medication, which again poses a unique challenge and more challenge for health service providers. Then the practice by the general practitioners and use of antibiotics. There's rampant practice, and it puts question mark that how we can convince and how we can bring the general practitioner to understand the importance of antimicrobial resistance and how to control this practice of prescribing antibiotics. Apart from this, the non-allopathic service providers, which constitute homeopaths and the Hakims, they use steroids. There is rampant use of steroids by these healthcare providers. And we have ample evidence with us whenever our teams go and inspect these non-allopathic outlets. We not only observe, we catch these people, and we not only call them, but we also fine them for using allopathic practices and using steroids. Then there is a challenge of pharmaceutical companies through their medical representatives. While we were preparing for this webinar, I asked this question to my colleagues, that how our doctors, the undergrad level or at a higher level, how they are taught the dosage of these medicine. Although we know that in third year of pharmacology, we are taught, and then perhaps during our training in CPSP. But interesting answer came from one of my colleagues that basically these are the medical reps who teach the efficacy and efficiency and dosage of these medicine to doctors. Here comes the question of absence of a national formulary in Pakistan. And though we have a list of medication at the federal level, DRAP perhaps had prepared the list of essential medicine, but formulary like the national British formulary, we do not have any book or formulary of that standard. So this is a missing link. And again, one of our colleagues will talk more during her presentation. But I mean, this is how we are taught the use of and the dosage of these medicines. Again, I would say the role of quackery in promoting, or they again play a dangerous role while using antibiotics, while using steroids and injectables. We also, I mean, as a regulator, we take action against these quacks. And so far, we have conducted more than 200,000 inspections of these quackery outlets. And due to our efforts, we have closed and sealed more than 40,000 quacks. Then we are a country where we have a shortage of doctors as well as of nurses. If we assess the presence or availability of doctors and nurses on the basis of our population, so we all know that there's huge deficiency in terms of numbers and nurses and technicians. Then we have a culture of non-reporting of areas, and the issue of training, this lack of training. So if you allow me, I would say that as a nation, we are perhaps not tuned towards quality. Therefore, there's a number of gaps and deficiencies which I have just pointed out. In a nutshell, I would say it's a complex and interconnected system. On one end of the spectrum which starts from registration and manufacturing of medicine, and on the other end of the spectrum is the patient itself. So the security, safety of patient, which is fundamental rule, I would say that all the health system revolves around safety of patient. So the safety in administration, or the safety in administration of medication perhaps is the I would say, linchpin in the health system. And core issue, as I said earlier, lies in our systemic weaknesses and gaps between knowledge and practice. Although our doctors have adequate knowledge, but the way we practice our knowledge, there are question marks. I would say here comes the role of leadership of hospital or of HEC and management to inculcate the culture of clinical governance, because as the today's title says, that it is not one man's job, it is perhaps teamwork, and we all have to work together if we want to overcome the deficiencies. In the end, I would like to just narrate the role of Punjab Healthcare Commission as a regulator, that what we do and what we have done over the last few years. As a regulator, we have a whole area, a very critical area of management of medicine, under which we have 3 standards and 25 indicators, which specifically deal with management of medicine. Apart from these standards and indicators, there are other associated indicators which basically deal directly or indirectly with the issue. Apart from this, whenever our team goes and we find any problem in emergency or in clinical disposal of hospital waste, we definitely take action, and we also issue regular advisories and directives to the government and to other stakeholders for bringing improvement and quality in service delivery of medication. For example, last year, several cases of blindness were reported due to off-label use of a drug for treatment of diabetic neuropathy. Accordingly, PHC not only issued guidelines, but also developed a training video, which is available on our website and on our social media platforms. In another case, some areas were reported due to some areas leading to deaths were reported due to mix-up of Ringer's lactate with normal saline while administering ceftriaxone antibiotic to children. Accordingly, we took up the matter with concerned authorities for change of color of the label of these Ringer's lactate and normal saline. I have also brought these 2 bottles to show to the audience as well as to our speakers and other, that how important is these look-alike or sound-alike matter is, because these 2 medicine, normal saline and Ringer's lactate, they are supplied and available in the same label, which can create confusion. So this is one bottle, same color and almost same label. This is Ringer lactate, and this one is normal saline. So that shows the importance of the basic principles that we should be trained and cautioned while using these materials. And some deaths were reported, and incidentally and erroneously or by error in a tertiary care hospital, Ringer's lactate was used instead of normal saline with an antibiotic and causing deaths. As I said earlier, that as a regulator, we also take action against facts, and other advisories are also issued on the issue on the matters of emergency and on infrastructure also, and how to control infections. So there are a number of advisories and other directives which we usually issue. With these remarks, I would now invite our other guest speaker, Dr. Uma, who will give another short presentation. And I again thank you, all the participants, all the distinguished speakers who are with us here and who have joined us online. Thank you very much.
Thank you. Some examples have been shared, very interesting examples have been shared with you by our CCO, Dr. Mohammed Saqib Aziz sir. You all know the definition of medication error. Anything which is not done by the way it should be done will be called error. But here we will be talking about errors which are preventable, but can cause or lead to inappropriate medication use or patient harm, while the medication is in the custody and control of the healthcare professional, patient, or consumer, so that we can advise and they can change their practice. And next time, the medication error are not there. So let's see what does the data talk about it. Before we go into the data, you can see the things which Professor Dr. Saab was talking about, and on the down left side, you can see a case of ulcerative wound of wrong injection on buttocks, mostly the IM injection, and it has resulted in ulceration of total area. So this is when you go to quacks, and this is what happens. So PHC carries out raids and inspection of its facilities and hospitals and control this menace of quackery, but people should also be aware of this fact that the quackery outlets are not solution and they do not provide the real help. Actually, they bring more harm. So this, you can see, is one of the big causes of medication harm in our country, that the medicine or the medical practice is being used by unprofessional people. So when we look at the global situation, as the Dr. Saab has told you, the facts and figures, I would just like to point out one fact, that out of the 50% preventable harms caused by the medication errors, 5 to 40%, 41% lead to admissions. That the patient get admitted to the hospital. The errors are so critical. And these medication errors are more in the population which is on 2 or 3 or 5 medicines, more than 5 medicines. So the more the medicine you take, the more is the chance that the medication error will be there and there will be problem regarding the medicine. And that's why the geriatric population is more vulnerable to this issue due to polypharmacy and comorbidities. This is an interesting layout we have prepared for you to put in one slide all the stakeholders which are involved in the medicine use process. You can see who makes the medicine enter the country, that is DRAP, Drug Regulatory Authority of Pakistan. And then we have Ministry of Health, National Ministry of Health. And then we have provincial government, which looks after the drug sales and distribution, compounding practices, as well as also administrates the hospitals which are under their control. Then we have manufacture, a totally private sector. The two main responsibilities of the manufacturer being holding on to the current good manufacturing practices and produce good quality products, and also carry out ethical marketing and post-marketing surveillance, and carry out corporate social responsibility activities to safeguard medicine safety. Then comes the Healthcare Commission. The Healthcare Commission, like Punjab Healthcare Commission, regulates the HCs, whether private or public, and develops standards and train the people on these standards, and then monitors how these standards are implemented. A big role, which is mostly not identified and not taken into account, is of public and the people who play a major role in forming the perspective of the public on the medication safety or health, like media. So the issue, for example, regarding medication safety is this, that now and then on print and social media, you will see, or electronic media, you see that people are advertising medicines directly to the people that use these nutraceutical, use these painkiller and so, which is very unethical. And patients, without having any knowledge of the dosage and clear knowledge of the interaction which can take place, start using these medication, resulting in more harm than benefit. The other issue is the literacy rate of our population, the culture of quackery, and the affordability and socioeconomic issues. So we have to collectively endorse all these problems and do not go into denial, and collectively form an action plan to address these. I would like to bring to you how we all are to be involved, and not just one person or one organization can deliver this role. For instance, we all know that Drug Regulatory Authority, WHO, and FDA, all these regulators, they issue drug alerts. So I'll talk about two drug alerts and give you the example that in 2019, domperidone, motilium, was withdrawn from the use for children and adolescents below 35 kg body weight, because there were sudden cardiac deaths involved with its use. So the alert was issued by the National Regulatory Authority. It was issued by the Provincial Drug Control. It was also perhaps circulated to the SCs. But if nobody is going to monitor whether this alert has been implemented, and domperidone, brand name motilium, is still being used for children, risking our patient's life, then whose role comes here? So it means just regulators' role is not enough. SCE's roles, healthcare facility, healthcare professional, that they should be updated, they should comply to the actions which are being given, along with the alert that when they say no more motilium to be used in children, then it means no more. The other example is the use of sodium valproate in women of reproductive age. This alert was internationally circulated in 2019 and again in 2023 by WHO, DRAP, and all the regulators worldwide. Because the product, which is very old and safe, considered to be safe product, has now proven teratogenic effect. So keeping up to date is not something which I like and it's my hobby or it's my interest. It's an obligation in healthcare. So that is why Punjab Healthcare Commission has introduced monitoring of the drug alert compliance in its performance assessment evaluation, which is done with all the Category 1 hospitals of Punjab. The other key concern is what happens when these medicines are brought into the country. It is seen that these products lie on the ports for days and days, waiting for the clearance from the various institutions, because various institutions are involved in the clearance, so the delays are there. Ultimately, the product which would be actually bought by the hospitals or the government or the people, somebody would buy it. This product loses its efficacy sitting there on the port in the strong scorching sun. Then we come to the public. It's the antibiotic and medicine, self-medication and use without prescription. This is a biggest of the hazard of all these. So the medicine used without prescription, especially for antibiotic, results in many problems, including antimicrobial resistance. And the chances of adverse effects and side effects also gets many a time increase. The 2 points which I would like to now close this important slide on is this: what is the role of pharmacist and how the public and the practitioner or the nurse can learn how to safely use the medicine. I take a simple example of paracetamol. Do we know how to take paracetamol tablet? Have we been told how many tablets to be taken at one time? And after how long we should take the next dose and how many tablets we can take in the whole day. We all know take 2 tablets when you have fever. But how many tablets? The fever is not going away. Now, how many tablets I should take? If I have a liver failure or liver dysfunction, can I take paracetamol tablet? So these important messages, we are not doing research to create it. We are just asking that our pharmacists, our hospitals, our retailers should deliver these messages compulsorily, mandatory, because it affects the life of it. Now, the paracetamol, if used without these instructions, will be more harmful than useful. So, a very small thing, just saying few words. If you cannot say these few words, the other simple way of doing this, put it in the patient information leaflet written in the local language. It will solve the problem. So if you can't read English, if you can't read technical information, you can do the indigenous native language patient information, and you can get the safer use of medicine. Other example is ciprofloxacin. We have stomach upset, doctor prescribes us ciprofloxacin, and we take ciprofloxacin with milk, or we take it with calcium, or we take it along with our iron tablet, or in diarrhea, some prescriptions are also there for zinc. So in this case, ciprofloxacin interacts with the minerals and does not get absorbed. It's an important antibiotic. It will not reach your bloodstream and it will not deliver the function. Your money is lost. So these examples are enough to sensitize us that we all, public, healthcare professionals, doctor, pharmacists, nurses, health administrators, regulators, all should identify our role and deliver to it. So here in the coming slides, I have given some examples of what are the major lacking areas, like the one mentioned, that the absence of national formulary. A formulary is not a drug list. It has all the prescription and handling details along with counseling instructions in it. Then it could be called a comprehensive formulary, just like British National Formulary. Then the other thing is this, which piece of paper will be called a prescription? What is the minimum component of it that should be fulfilled, that someone should cater it? And how many times this prescription can be refilled? Is there any refill status given on it? When it gets dispensed, does it get stamped for being dispensed so that it is not used again? Prescriptions, हम steroids की भी हमारे पास होती हैं. डॉक्टर साहब एंटीबायोटिक प्रिस्क्राइब करते हैं, एंटी कैंसर्स प्रिस्क्राइब करते हैं, हॉर्मोन्स प्रिस्क्राइब करते हैं. अगर एक प्रिस्क्रिप्शन इसी तरह बार बार डिस्पेंस होगी तो it would be injurious to the user. So Punjab Healthcare Commission has designed a guideline for the prescription format. Our stakeholders can have a look on it and can adopt it. And this has the refill statement, the dispensing stamp place, and all the other components along with the detailed guideline how to use it. So this can be the starting point for our country to go on medication safety using a standard prescription format. Similarly, with nurses, it is seen that transcription seems to be the most common error. Calculation and administration issues are there. We know that we have to make high alert medication list and the LASA medication list, but very less nurses and the staff knows about how to handle these issues. We have talked a lot about self-medication and quackery by now. The other thing which is associated and related to it is the absence of a notified over-the-counter medicine list, which will help reduce self-medication, which will help reduce quackery and organize the dispensing system at the retail outlets. These few slides actually will show you categorically what are the standards which are in the MSTS produced by the PHC and implemented in Punjab for the medication safety. These are the ways we deliver our information in social media posts through our MSTS. So one important thing, which is a new thing, which I would like to talk about here, is the addition in performance assessment system of, like I said, drug alert updates, antibiotic stewardship program, pharmacovigilance committee monitoring, and working of Pharmacy and Therapeutic Committee. Now the hospitals have to report that in 6 months, what these committees had been doing, what was their agenda, and were they notified and working or not. Regarding the safety accident incidents which happened in Punjab in last 2 years, as Dr. Saqib has briefed, we had issued one important advisory regarding this interaction of ceftriaxone and calcium. It is an interaction which came up in the last 5 years, and then the instructions in all the documents changed on how to use ceftriaxone, and its calcium interaction and mixture with calcium has to be avoided. In June 24, an incident occurred, and we issued a directive, an advisory on how to use ceftriaxone. And then later a bigger incident happened, and then we gave trainings, and then made this a part of our performance assessment to evaluate whether people are reading the advisories or not, whether they are implementing the advisories or not. These are the videos, series of 3 videos we have prepared for bevacizumab intravitreal injection. You can see here the look-alike products are sitting side by side so that can cause mishaps. You can see in this slide that the ADR and the medication error reporting are so minimal that very less hospitals are reporting these in public and private sector. Now, these last 2 slides are about the recommendation. One recommendation is already placed by our respected CEO Saab, that there should be a national formulary and guide to which we all should refer for guidance, that what is the correct dose, how we should use the medicine. Then we have the standards in place. There should be an effort from the HCEs to implement it, to adopt it and own it. And then there should be standard format for prescription writing, and there should be a legal support system to back these changes. All these things also require some legal changes. Then there should be clinical pharmacists available in the facilities in adequate number to deliver all these roles, to provide all these information to nurses and doctors and other people. It would be better that things are computerized in this age. PHC is also taking this initiative of mobilizing the HCEs to turn towards computerization and digitization. We look forward that the pharmacovigilance system in the country is more accessible, that the people and the retailers also know about it, not just certain public sector hospitals. There should be openness in research, and there should be training of pharmacists during their PharmD degree in the hospitals so that they learn about delivering these services clinically in the clinical team to the patient. Public health advocacy should always be there, and there should be emphasis on antimicrobial stewardship. So with this, we thank our presentation from PHC and hand over to the moderator for inviting other speakers. Thank you.
Thank you, ma'am. Thank you. Thank you very much. Or thank you, CEO Saab, for building the context, and ma'am for sharing with the participants the initiatives taken by the Healthcare Commission as regulator of the healthcare system. Our next speaker is Professor Khalid Masood Gondal, who is incumbent President, College of Physician Surgeon, Pakistan, and Vice Chancellor, University Fatima Jinnah Medical University. He is an accomplished leader in the medical education and a renowned general and laparoscopic surgeon. And he also holds doctorate degree in medical education. He's been involved in educational institutions and education settings in the healthcare system for a couple of decades almost. He was also awarded Performance Award as well as the Tamga Imtiaz by the President of Pakistan on his accomplished activities and performance. I would request Professor Khalid Masood Gondal Saab. He will be sharing the adverse events in the healthcare settings leading to medical errors. Over to you, Professor Khalid Masood Gondal Saab, please.
Bismillahirrahmanirrahim. Nahmadu wa nusalli ala Rasoolil Kareem. Mushtaq Saab, आवाज मेरी आ रही?
जी, very clear जी.
Thank you. I think I must thank you and the CEO, Saab, Dr. Saqib Aziz, for inviting me on this very important topic, very important, rarely discussed medication related adverse event, and what is the national or international perspective, and what are the strategies we can make at our level, how we can adopt the international strategies to reduce the patient harm. Now, I'll be discussing the definition and the scope, which has been partially discussed, the global burden of the medication related adverse events, current status in Pakistan, common cause of high risk medication, what about the reporting system and what are the barrier, and evidence based strategies, how we can reduce these harms, and what about the policies and the leadership, and what is the implementation roadmap, and then finally the conclusion and the recommendations. Now, I think just has been defined the medication related adverse event, any injury resulting from medical intervention related to the drug. An error is the preventable error that may lead to inappropriate medication use or patient harm, whereas the adverse drug reaction is the harmful or unpleasant reaction from a drug at the normal dose. The way forward I have been discussed, I think, just by Madam, how we are going to make the policies in the prescription, the dispensing, the administration, the monitoring, and whenever there's transition of the care at the discharge or entry of that patient. The global burden of this medical error that's there, medication error are amongst the leading causes of the avoidable patient harm worldwide, globally and nationally. And WHO time and again highlights medication safety as a global priority. Many patients are affected annually. Whereas the reporting system is concerned, the reporting is undermined. High income and low middle income countries both are affected, but data captured that is varied between the developing and the developed world. The global data, the statistics, as been mentioned before my presentation, 1 in 10 patient harmed during the hospital care in some setting. And the medication error, that is a major contributor. Maybe there are different reasons that has been discussed and that will be discussed. Adverse drug event increases not only the length of stay, the morbidity and mortality of patient, ultimately affecting the cost on those patients. So the high risk and vulnerable population are those who are admitted in the intensive care, in OR, are emergency patients, pediatric patient, geriatric patient, and patient having the multiple morbidities. As far as Pakistan is concerned, we all know there is a limited national pharmacovigilance and fragmented reporting system. Reporting system is undermined. The study which we see at the large scale, they are only from some of the tertiary care center or the occasional data that is available. In Pakistan, our observation is the common errors that has partially been discussed are during prescription, and I am very happy to see the prescription pattern that has been presented, then the wrong dose, and we all know we have to observe all those things, right drug, right dose, right patient. So these things cannot be omitted. Similarly, the administration mistakes, the intramuscular injection going IV. The people have injected into the arterial artery, and that has led to the spasm of the artery and ultimately the gangrene of the arm. The contributing factor may be the heavy workload, limited clinical pharmacy services, or the training is compromised, which we need to address. And the root causes are the human factor, maybe the fatigue. We have to define the working hour as per the international standard. Similarly, we need to improve the communication, interdepartment communication with the patient, and soft skill are very important. I think the gap which is in our medical community, professionalism and ethics, empathy, understanding the grievance of the patient, and there's inadequate awareness and the training of our doctors. The system factors that include there are weak SOPs and the monitoring as far as this important aspect is concerned. weak clinical governance, and poor medication reconciliation. At organizational level, we need to address if there is a shortage of staff at the medical side, paramedical side, or the nurses. The governance and leadership issue, they are there and they need to be improved as far as this aspect is concerned. Now, there are high risk medication. We need to be more vigilant in those like the anticoagulant, the insulin, opioid, chemotherapy, and there are cases. You have just shown us the similar labels and the drugs, they are different. People have injected potassium IV stat instead of putting into the dip, and there is stat adverse drug reaction, and sometimes the mortality is also there. Similarly, we need to be more careful during the admission time, discharge time, whenever you are handing over the patient or you are using the drug in the emergency. You have to be more vigilant. And the drugs which look like, sound like, and we have already mentioned that we are going to have a different label and we are going to issue the guideline for them. Similarly, the storage of the drug, I think the expiry date, the labeling of drugs, these are other important things. As far as the reporting system and the barrier they are concerned, pharmacovigilance discussed already, but there is a partial coverage. That is not the perfect. Reporting system mainly is through the DRAG. The barrier they may include why we are under reporting. Fear of blame, lack of feedback, cumbrous reporting process. It has to be simple, and the people they are not aware of the reporting system. Data is fragmented between the public, private, and provincial system, and there is overlap of the regulatory body. PMDC role, DRAP role, Healthcare Commission role, College of Physicians Surgeon role, and these overlap have to be defined as per their mandate. As far as the strategies they are concerned, we have to identify the high-risk drug and vulnerable group. The drug similar and the patient admitted in which unit, we have to see that vigilance, awareness, training and monitoring at under and postgraduate level, standardized medication reconciliation at all the transition of care, then electronic prescription with clinical decision report. That is the way forward. That is the future we have to shift toward the electronic prescription with a barcoded medication administration and smart infusion pump in high risk area. Now these strategies, they are obviously we have to increase the awareness at the grassroots level. We have to include and inculcate these things at our undergraduate and postgraduate curricula. At the level of the College of Physicians in Pakistan, we have got 5-6 workshops which are compulsory for all the postgraduate residents. I am very grateful to the Healthcare Commission, Dr. Saqib Aziz and Dr. Mushtaq Saab. You are already addressing the soft skill. You are already taking, I think, 1 or 2 hours during our communication skill workshop, and in future we will consider the incorporation in the curriculum of post-graduation as far as these training courses of the workshop they are concerned. And then the introduction of standardized protocol, the checklist, the readback communication of high-risk medication. Checklist is very important for the right drug, for the right patient, for the right dose, and strengthening of clinical pharmacy services with multidisciplinary round. Regular competency-based training and evaluation of the prescriber, not only the doctors, not only the postgraduate, but our paramedics, our nurses, the pharmacists, their training is a very important and a way forward which includes the future vision. As far as the reporting and safety culture is concerned, we have to establish initially, to start with, a non-punitive, anonymous reporting system with timely feedback. That's very important. Implement local. I think we must have the committee, and we have already given in SOPs the committees, they are going to be there, and regular mortality meeting focusing on the medication safety. Use data to drive local quality improvement. The PDSA cycle, plan, do, study, and act, and publish the aggregated finding for the future vision or the future way forward. As far as policy, governance, and leadership is concerned, we have to create a national medication safety strategy, which already had been mentioned, guideline at the level of MOH, DRAP, PMDC, CPSP. They should play their own role, including the university. We should ensure the regular healthcare and public awareness campaign at every institution at provincial and the national level. And we should mandate minimal clinical pharmacy staffing and the safety officer in every tertiary care center. And obviously in postgraduate and undergraduate curricula, these are the important aspect which has to be considered. Now, these implementation roadmap, according to myself and in my opinion, the first year, we should have the baseline assessment and stakeholder mapping across the provinces. Make a strategy. Then a pilot project of non-punitive reporting in the selected hospital and establish a feedback channel in the hospital with Healthcare Commission at the central level too. Start focusing training for high risk area and vulnerable group like the patient admitted in the ICU, ER, pediatric, geriatric, multidisciplinary. We can prioritize these patients initially and these area initially. Then in 1 to 3 years, the scale we should go for the electronic prescription in a phase-wise manner, expand clinical pharmacy services, establish a regional center for medication safety and data aggregation. And finally, the integration. Integrate medication safety metrics into hospital accreditation and medical education standard. Whenever Healthcare Commission, I am sure this will be your policy, are going to visit and accredit the hospital, and we will try to include these things at the level of CPSP2 whenever we are visiting these hospitals for accreditation purpose. Now we should also consider in the measurement and key performance indicators. What are the number of reported adverse reaction, and similarly in NLE competency pass rate for medication safety module in under and postgraduate examination. Evaluate those trainee, how much they know, how much they are practicing, and what is the outcome. And what are the hospitals where there is a reduction in the high risk medication incidence and medication related morbidity and mortality. Their incentive, their promotion, that should be related to these indicators. Anticipated challenges, we all know. Resource constraint, we have to prioritize high impact, low cost intervention first. Resistance to a change, that is there. But the leadership very is important. If the leader is the role model and he is leading the institution, the follower will go and follower will follow the vision. Then data quality issues, data should be initially the simple in the report is the simple one, and gradually we can update that data, and there should be a regular audit system at the level of the institution, at the level of Healthcare Commission. And in conclusion, I would say medication related adverse events are preventable with system thinking and the leadership. These errors, they are there. They are there in Pakistan, they are everywhere in the world, and they are preventable. But the leadership can play a role. Academia and stakeholder can lead by embedding safety into the training policy and practice. The immediate step, which is start a pilot reporting, strengthen clinical pharmacy, and start curriculum integration at under and postgraduate level. Thank you very much, Dr. Mushtaq Saab, CEO Saqib Aziz Saab, and everybody who is listening. I think I can see on the screen, and some people I cannot see on the screen, for giving me the chance to discuss a very important aspect as far as the quality service delivery is concerned, patient care is concerned. And I personally feel खैरुन नास भाई यनफउन नास, इंसानों में बेहतरीन वो जो इंसानियत की नफा रिसानी के लिए काम करे. एक जान बच गई, हाथ उठ गया, दुआ आसमान पे चली गई, दुनिया और आखिरत बन गई. आप सबका बहुत शुक्रिया. And this is the reference for my presentation which I have discussed. Thank you and thank you very much.
Professor Khalid Masood Gondal Sahab, President, College of Physician Surgeon, Pakistan, and VC, Fatima Jinnah Medical University, for sharing your insight into very important aspect of medication safety, which is medical related errors in the healthcare settings. Or thank you for the update. Let me also share with you that you are at this point in time being joined by 110 people who are watching your presentation and discussion. Definitely, as you informed and you discussed, the Commission has ventured into creating a culture of non-punitive reporting of medication errors and as well as the sentinel events taking place in the hospitals and in healthcare settings. Thank you very much for your insightful. Our next speaker on this panel is Professor Masood Sadiq. He is Vice Chancellor, University of Child Health Sciences, Lahore. He has been earlier Dean of the Child Health Institute, Lahore. On his extensive service to the promotion of child health services, child health sciences, he has been awarded Tamga Imtiaz by the President of Pakistan. He is a renowned pediatric surgeon, and he'll be talking about the special considerations for medication safety in pediatric age patients, as there are certain special considerations for certain special situations like pediatric, geriatric, pregnancy, and other situations, and breastfeeding. So, Professor will be talking about special consideration for medication safety in pediatric age patients. Thank you very much, sir, for joining, and over to you, sir.
Bismillah ar-Rahman ar-Rahim. Am I audible?
Thank you.
जी बहुत शुक्रिया सुलैरिया साहब मेरी आवाज आपको आ रही है
Very clear, loud and clear.
Thank you very much. I think we had a very comprehensive presentation from CEO Dr. Saqib Saab, and subsequently, of course, from our colleague and then Professor Gondal Saab. My perspective is fairly simple, and I would be very brief as well, because I would be talking about medication safety. What are the special considerations in pediatric age group? I would start by just reminding everybody that pediatrics and child health is a universe of its own, actually. And children are not small adults. And I think that's where we make the maximum mistakes, because we start thinking that children are small adults. They are not. And in a country like Pakistan, and you can see the population pyramid on your right compared to a developed country, that we have about 47.8% of the population as pediatrics under 18 years of age. So we have one of the third largest pediatric population. So I think the perspective has to be also understood under the context that 1/3 of our children are underweight. So they have special considerations. 44% are stunted. They also have a special consideration, and 15% are wasted, and half of them being anemic. So we have one of the very vulnerable pediatric population around the world. I think I wouldn't talk about medication safety per se. It's prevention of errors and adverse effects, because that has already been spoken to. I think one must remember that medication are not only in prescription. They are in prescription, they are in transcribing, they are in dispensing, they are in administration, and they are also in monitoring. And that's regardless whether an injury or potential injury has occurred or not. And most frequently identified errors in pediatric age groups relate to the use of adult formulated medications and the need to change original dosages. And I think that's where we make maximum mistakes. According to Joint Commission, potential adverse drug events occur as much as 3 times more often in pediatric patients than adult patients. So I think the scope is tremendous when it comes to pediatric population. So what are the challenges when it comes to children? I think the first and the foremost challenge is weight-based dosing. In pediatric population, we would typically calculate dose based on child's weight in kilograms, be it milligrams or micrograms, and then body surface area, rather than age alone. And I think this is a very important context, and this requires precise calculation, which obviously then increases the potential for dosing errors, because you can make decimal point errors. The second important context to be remembered in pediatric age group is age-dependent pharmacokinetics or organ maturity. We have neonates, we have preterm babies, neonates, infants, young children, older children, adolescents. And I think infants and young children have a developing kidney and liver, which can affect a drug's metabolism and elimination. And this may prolong drugs' half-life. That's why when we are calculating doses, we need to see if it's a preterm baby, a term baby, an infant, or an older child. Now, we must also remember another challenge is body composition difference. Neonates and infants have a higher percentage of total body water and a lower fat content than adults. And this again affects how drugs are distributed. And particularly, I think you need to weight adjust them and whether you need to see whether they are water soluble or not. I've given few examples of water soluble drugs like paracetamol, atenolol, diclofenac acid, diltiazem, and I think they achieve different therapeutic levels at different times. Similarly, when it comes to adverse effects, due to these physiological differences that we have in pediatric age group, some drugs can cause unique and very severe toxic effects. I'm sure everybody is aware of Ray's syndrome, which occurs with a dose of aspirin, which is taken by adults like everyday thing, but it can cause such a huge harm in pediatric age group. Or similarly, gray baby syndrome with chloramphenicol. And then you have communication barriers. Children can't speak for themselves. We have to speak for them. Their parents have to speak for them. So young children and infants cannot easily verbalize symptoms, pain, or side effects, making it difficult to monitor for drugs adverse effects. And then another important challenge is the formulation and administration. Most medications are formulated and packaged for adults. So that causes a huge poses huge administration challenge, like 1/8 गोली का हिस्सा, 1/12 गोली का हिस्सा, 1/4 गोली का हिस्सा. And I think then that's where the maximum mistakes are made. And then there is a lack of suitable child-friendly formulations. We still struggle with a lot of drugs because they do not have soluble or liquid strengths or chewable tablets. And this often necessitates manipulating adult tablets, which are either crushed or splitted. आप जाएंगे फार्मेसी पे तो वो कहेगा मैंने इसके अंदर थोड़ी सी चीनी मिला दी थी या मैंने शुगर मिला दी थी या मैंने ग्लूकोज मिला दिया है और ये मैंने आपके 8 parts बना दिए हैं. Now, how many of those 8 parts would have sugar only and how many of them would actually have a drug? It's total luck of the child. And I think this off-label preparation can lead to inaccurate dosing. And then obviously administration technique. Children have difficulty in swallowing and they refuse sometimes because the taste is not good or they are afraid of taking a tablet. And I think that using inappropriate measuring devices such as household spoons is a common cause of home administration errors. आपको भी पता है चम्मच can be 2.5 mils, it can be 3 mils, it can be 5 mils. And it depends the mother which type of spoon will she use, and that can actually change the whole context. And similarly, dosage form selection. We obviously would like to prefer a liquid, dispersible or chewable formulation and avoid choking hazards and alcohol-based excerpts. So how do we go about it? I think there are a few things we can do. One, and the first and the foremost thing is confirming which drugs are safe, are approved for use in children. And I think this is the first step of promoting medication safety in pediatric age group. And I think pediatric drug formulary or drug lists for pediatrics is obviously the first step. Always double check the dose. I think you can calculate dose and frequency as per gestational age of preterm. Is it a neonate? Is it an infant? Is it a child? And then the accurate dosing will again depend upon his or her weight. You might have a 3 kilogram neonate or you might have a 3 kilogram 1-year-old child because he has failed to thrive. So the doses are calculated in milligrams per kilogram or microgram per kilogram. And I think it's also important to know the current weight. We have seen major mistakes being done by somebody putting a weight on the chart, which was 6 months ago. 6 months in a child's life is a long time. particularly when it comes to infants. And if you're calculating dose based on a weight which was done 6 months ago or a year ago, you can again make a major mistake. Device accuracy is again important, using oral syringes or calibrated droppers. I always tell my patient to use a syringe rather than using a spoon. But I don't think that's a normal practice. Most of us would just write ek chamach, aadhi chamach, ya quarter chamach, and that's where people will make major mistakes. So I think using oral syringes which are calibrated or droppers which are calibrated and not household spoons to prevent dosing errors. And then, of course, monitoring. Who's going to monitor them? Frequent monitoring of renal function. You put them on atenolol or you put them on captopril, and you don't know what their serum potassium is. And in a child or in a 1-year-old or in a 6-month-old, you can cause a major harm to the child, but by not knowing their renal, hepatic, or therapeutic drug levels. I think communication and labeling, Professor Gondal also mentioned about clear written and, if necessary in pediatric age group, pictorial instructions to parents and caregivers. I think we must avoid abbreviations, and we should make sure that caregiver comprehension is there. Here you are teaching the mother, not the child. So we must make sure that we guide them about the exact dosage in which they should be measuring, how they should be measuring, how frequently they should be giving it, and what are the potential side effects. And of course, you have to come to the level of the education of the mother, which may not always be there. And please do not refer to medicine as a candy. It's not a candy. It's not a candy for a child. It's a medication. It's a poison. And I think that's how it should be treated. Safe packaging and storage. I know in the rest of the world, pediatric medicines have a special packing, which only an adult can open, and no child would be able to open them. I don't think we have that in our country, unfortunately. And most of the times, the medications are packaged in the same way as for adults, and they are not necessarily kept out of the reach and sight. And I think this is something which needs to be ensured. Involvement of clinical pharmacists, particularly in a hospital setting, is key for every setup. But I think it's more important for pediatric setup, because a small mistake in terms of writing microgram or milligram can create a havoc. And I think we must make sure that, particularly in hospital setting or where in pharmacies where doses are being dispensed for pediatric age group, we make sure that this is supervised by a qualified pharmacist. And of course, I think Gondal sir mentioned about the use of technology, implementing computerized physician order entry, or at least barcode medication. I think where this facility is available, or if we can ensure that, this is something which we must try and do. I would like to conclude by saying again, children are not small adults. They should not be treated like adults. And medication safety in pediatric age group is even more important because the margins are very small. You can really make a major mistake and a big harm. It requires special consideration due to significant differences in physiology, body weight, and development as compared to adults. And due to certain risks of size and age, I think medication error can lead to very serious and potentially life-threatening adverse effects. We must make sure that we create a pediatric medication safety training program and educate all healthcare professionals who are managing children, be it a nurse, be it a doctor, or any other health professional involved in that. And national and hospital-based. We have our own pediatric formulary at Children's Hospital Lahore. We have our own drug list also, which we provide to our prescribers. But I think there needs to be a national or a provincial, I think national will be more appropriate, and a hospital-based pediatric formulary to make sure that people know which drugs need to be used in pediatric age group. And of course, use of technology can decrease the errors at all levels. Thank you very much.
Thank you very much for your very important, elaborate presentation on special consideration for ensuring medication safety in pediatric age patients. As you have mentioned, age and weight is important in pediatric patients. हमारे जो सर्विस डिलीवरी स्टैंडर्ड्स हैं, जो रेगुलेटरी इन्फोर्समेंट हैं पंजाब हेल्थ केयर कमीशन की, both emphasis इस पे है उसमें कि particularly in pediatric patients, the medications should be calculated, the dose should be calculated on the not only on the basis of age, but also considering the patient's weight. And also, as you mentioned about special formulary for pediatric patients, playing a bit of its role, the Commission has advocated availability of pediatric size infusions and blood bags in the market, which are not available in our local context. So we have been advocating it, and we'll definitely emphasize on it. Thank you for your talk. Our next speaker, basically, very learned pharmaceutical expert, Dr. Asim Rauf. He's been Chief Executive Officer, Drug Regulatory Authority of Pakistan. He's sort of a doctorate in pharmaceuticals, and his vast experience spanning over 30 years in the pharmaceuticals. He's been instrumental in getting the DRAP, the status of WHO listed authority in terms of medication safety and security. So I would request Dr. Asim Rauf Saab. He will be talking about communication failure in medication errors. So maybe he can also talk about the role of artificial intelligence, the due role of artificial intelligence in management of medication in future. Over to Dr. Asim Sabri, Dr. Asim Rauf Saab, former CEO, Drug Regulatory Authority, Pakistan.
Thank you very much, sir. It is an honor for me to be here in this very important seminar, and that discusses how about the delicacies about giving the medicines. Although I have been involved with Drug Regulatory Authority of Pakistan, and I would have been much comfortable in delivering the steps taken by DRAP, but I am happy to let you know that one of our officers is also here, who would be briefing about the steps taken by DRAP to assure the quality of medicine. So I have been given the topic that is communication failure and how it affects. This is very simple topic, and I have tried to make very brief presentation, but this is a very, very important topic. I have personally witnessed, so many cases of affecting from the drugs and debilitating their health through the drugs solely and mainly due to the communication failures. We have discussed about medication errors. This is globally, this is a big concern. This is, nowadays becoming a huge concern. And WHO and all other major institutions, they are working to help and devise the policies. So when we see the definition about communication, the WHO defines most medication errors occur because of weak system and poor communication between health professionals and between professionals and patients. So the message from WHO is very clear, either it is weak system, and weak system plays a major role. And in addition to that, the communication between the stakeholders. So there are two major aspects involving, medication errors due to this subject. Then WHO gives solution, where we should be very clear, a timely and structured communication. That is the single most effective defense against medication errors and adverse drug events. The most ERPs arise from information gaps. And we all know that, very, very simple medicines, when we don't tell how to take, that results into something that causes harm. And these harms and these DRPs and these communication levels or communication gaps happens while we start new medications, or while we start taking or using medications, or adding or stopping medicines, while reviewing medicines, and while experiencing side effects or issues. So at every stage of using medicines, whether it is new or whether it is being used or as a refill, or whether we are experiencing any side effects, the communication can have a major role. FDA is the very strongest regulatory authority, and the perspective that FDA gives to us is that FDA recognizes communication failure as hidden yet major cause of medication errors. And FDA has identified common failures like look-alike, sound-alike, confusion due to poor verbal and written communication, incomplete verbal orders that misheard, or incomplete telephone verbal orders, failure in interprofessional communication, and inadequate patient counseling. So that are the common things that we have heard from other speakers too. Now, coming to the impact. WHO says 1 in 10 patients is harmed while receiving care, and due to this communication failure. Errors can increase operational cost by 20 to 25% in pharmacy and hospital settings. Then WHO also expresses that medication errors cost $40 billion annually worldwide. And in Canada, $1 to $2 billion are spent yearly in managing preventable medication-related harm. The important thing that I want to let you know about this impact is that, this is the impact that has been quantified majorly from the countries where there is a system, and there is some sort of system that exists. And the countries where they don't have the system, the situation can't be quantified. This 1 in 10, there may be 1 in 5, 1 in 4, and the amount that is $40 billion, the major portion from the countries which don't have the system. Now, when we don't have the data, so we don't have the money to spend to correct the things when we take or harmed by the medicines. The only thing is that we are, we have to pay, and we are paying through the deaths and debilitation through the medications that we are taking. So WHO and ISMP emphasizes structured tools. I have given one example. Apart from electronic prescribing, that is way difficult at the moment in Pakistan due to various factors. The major tool that is being stressed upon by the authorities is SABR. So that is situation, background, assessment, and recommendations. I have tried to explain it through one example. Like a patient, AQ, has been prescribed metformin 1000 milligram twice daily. So the patient has come to pharmacy to pick the medicine, and where that pharmacist happen to know that recent lab results, which shows GFR 38 milliliter per minute. When we take the history, we see the background, what kind of medicines the patient is taking. We observe that the patient is also taking lisinopril and furosemide. So the question comes whether this dose is correct, or does this needs any intervention. Again, I would be stressing upon the point, this is a case that majorly reflects the countries where the system exists. In over scenario, like we are having 25 crores of people, we don't have the system where we can assess at this all this data, and we can intervene at the pharmacy level. So yes, the intervention is required here. Yes, this is required because this dose would increase the risk of lactic acidosis. Pharmacists working need to know and communicate that the dose should be reduced or some alternate therapy should be used. So this is the intervention. Let's say if intervention is not done, the patient can go to a situation having lactic acidosis and his life would turn into hell. So how SABR explains, S means the situation, that is the prescribed dose. The situation is that the dose has been prescribed by the doctor. B is the background, that is the medicines the patient is taking and recent lab work. And then assessment. Assessment is complications due to that prescribed dose. And finally is the recommendation that has been given. Now for assessment, we need to have the trained people. And that is the main question that we always ask, whether we do have trained people in Pakistan or not. So I would explain two examples where the communication has affected and has proven to be lethal. And these are examples which I have seen and witnessed myself. There was a lady that was, her age was 60 years old approximately, and she died due to some complications that were some heart complications. And when I happened to go there and I talked about what kind of conditions she had and how that happened, like, she was not supposed to die. She was young, she was doing fine, and she was doing fine with the medicines and living happy life. The son told me that she had developed the bluish patches on her body. And when I asked about what kind of medicines she were taking, so he told me that she was taking warfarin. So I asked whether you were taking her for monitoring. They said no. So ultimately, the dose that she was on that caused her to have complication from that simple step that could have been avoided if we could have communicated with the family or the patient, and that lady could have been living, even now at this point of time. So then another case, 82 years old patient hospitalized and was on vent. She was on vent for 1 day, ventilator on 1 day, and but that patient was using Seroquel every night. While taking the history during the admission to the hospital, it was explained very thoroughly that the patient is taking this kind of medicines, and was also categorically told them, and they wrote that she is also taking Seroquel. But after 3 to 4 days, when she came out of that ventilator situation, the fourth night she became very irritated. She had insomnia, anxiety, agitation, and restlessness. And those 5-6 hours that were very difficult to handle that patient. When the assessment was done, with the hospital staff and the doctors, so it was noted that the hospital didn't take care about the withdrawal symptoms about Seroquel, and they didn't do sufficient management to tackle that situation once, like after 4 days, because we know after 1 to 4 days, there are withdrawal symptoms. What steps they could have taken. So they didn't know the consequences, and ultimately that patient died. So I just want to let you know what was observed, that there was lack of training, there was lack of the impact, that if someone is not being given a medicine, what kind of impact would be there on the patient's life. So we have so many examples on daily basis like this. When we see in Pakistan, unfortunately, there is when we say training of pharmacists, so this is a question mark. Personally, I think apart from the few hospitals in Pakistan, the pharmacists are not well trained. They don't know, they are not being given the task, and they are not being relied upon while taking decisions in terms of giving medicines to the patients. Then whether we are reporting these interventions or not, that is another important question. Despite the best effort that RAP has undertaken, it is unfortunate to let you know that the hospitals, even tertiary care hospitals, they are not responding. They don't respond. And despite the best efforts of WHO and other stakeholders in Pakistan, we have not been able to persuade the institutions to respond and report to the trap. The pharmacovigilance system, Zia Saab would let you know about that. We have been trying to establish, but unfortunately at provincial level, we have faced a great difficulty. The pharmacovigilance system factually doesn't exist. And then finally, quantification of data. We don't know where we are standing. Like Hazrat Ali says, who he doesn't know where his status is, he is destroyed. So we don't know where we stand. We don't know the deaths that are being caused by the errors and communication errors, harm, and economic burden. If we say that $40 billion are being, is the cost of such effects, but we don't have the data about Pakistan. So unless we have a strong commitment and a strong system, perhaps we would be losing our people, and we would be, paying the cost in terms of the lives and the quality of life. Yes, thank you very much.
Thank you very much, Dr. Asim Rao Sahab, for your very valuable deliberations on communication errors leading to medication errors. ख़वातीन हज़रात, जैसे शुरू में कहा गया था कि medication safety, medication management is a multi-stage complex subject involving not only the pharmaceuticals as such and the pharmacy professionals, but also the educationists and the clinicians. So the professional knowledge and their perspective is very important. And it is this with this background that we have requested Dr. Harun Hafiz, who's Director Quality and Patient Safety at Shaukat Khan Memorial Cancer Hospital and Research Institute. He's there as internal medicine and palliative consultant. As Director Quality and Patient Safety, he's been instrumental in getting this hospital, Shaukat Khanum Hospital, accredited and re-accredited by the Joint Commission International. So he will be sharing with us human factors in medication errors. Over to Dr. Harun Sabri.
Thank you very much, Dr. Mushtaq. And first and foremost, a big thank you to Punjab Healthcare Commission for inviting me on this forum, but also more importantly, for taking on the role of educator alongside the role of a regulator, because regulation is very important, but it works truly in the best way if regulation is accompanied with education. So I am very grateful to Punjab Healthcare Commission for bringing in this topic and talking about medication errors. The topic that I'm going to talk about is human factors in medication errors. And when we talk or say the word human factors, the first thing that springs to our mind is that we are going to talk about errors of medication or medication-related errors that have happened because of the humans involved in handling those medications, whether they were nurses administering them, whether they were doctors prescribing them, or whether they were pharmacists dispensing them. But actually, we have to understand what human factors means. Human factors is a new science that is evolving in the field of patient safety as an area of interest, to the extent that they are now actually specialist certification and degrees in people who specialize in analyzing human factors in not only patient safety, but industrial safety as a whole. So when we talk about human factors, we actually mean environmental, organizational, and individual related elements which influence the human behavior and the performance in a work setting or in a work context. The UK Health and Safety Executive actually says human factors has 3 domains, including the task. When I say the task, what is being asked to be done? How complex is it? What are the demands of it? The individual who is being asked to do this task, what are their skills, what is their experience, what is their physical and mental state, and the environment or the organization in which this task is being asked to do. And if we look at all of these individually, we can understand that human factors in any errors or in any industry is not just related to the person delivering the task, but it is a whole umbrella of things that are happening around that person. I always say this to many people that if you take the top or the brightest student of a class 9th in a school and you give him an examination paper of FSC level or a class 12, grade 12 level, and if he doesn't pass, then you say that, oh, he's not a good student. Then that's not, you're asking somebody to do a task which they are not trained for. So for example, there's a common saying that if you assess elephants on their capacity to fly, then all birds will pass and the elephants won't. So everybody has their own use and their own limitations. Similarly, the task, every task has its own demands. If we do not have the right tools to carry out that task, errors are going to happen. The environment has an impact. If we do not have the right environment for a task to happen, if it is too noisy, if it is disturbing, if the right culture is not there, then obviously that will promote errors. So the key components of human factors or human errors are cognitive factors, which include attention, memory, decision-making, and perception, physical factors, psychological factors, and organizational factors. And I'm going to touch on all of these very briefly. As I said, when we talk about human factors and errors in safety, it's a whole new field in itself. So in 15 minutes, I'm not going to be able to cover all of it, but I just want to sensitize you guys or the participants of this meeting to what human factors are and how we need to be mindful of them when we are especially investigating adverse incidents. Because we've talked about blame-free culture, we've talked about reporting culture to be developed. But the problem is when we have a good reporting culture, but we do not have a good investigation culture, or if we have a culture where the blame goes to the individual at the front end without looking at the systems or having systems thinking, then your reporting culture is never going to be, you'll never develop a good culture of safety in your organization, whether it is an organizational level, at a national level, or a provincial level. We've already discussed the definition of medication error, so I'm not going to bore you by repeating it. We all know well what a medication error is. We've also discussed slightly where errors happen, but I'm just going to remind you all that errors can happen when you're prescribing, when you're transcribing, when you're dispensing, when you're administering. And most importantly, post-administration monitoring of medication for medication-related side effects is very example. As the speaker before me gave us the example of warfarin being dispensed to a patient, but not being educated about regular INRs and monitoring. And if that was not put in place, it eventually led to the patient to bleed to death. I would want to mention one more thing here to make you sensitize you to this, that there are active human errors and there are latent human errors. Now, active human errors are where the error is apparent due to a direct or a visible action of a frontline staff. So, for example, if I had to program an infusion pump at the rate of 30 ml per hour, I accidentally programmed it at 300 ml per hour. Most of us would immediately think that the person who programmed it at 300 ml per hour is the one at fault. But I've taken this example Because if in an organization you have 50 different types of pump, and in a regular shift, if a nurse has to program 5 different types of pump, her chances of making an error will go up. And that thing is the latent cause of this human error, that when you look at it, or when you try to analyze why did this nurse make an error in programming the pump, you actually realize that there are 3 different types or 5 different types or 10 different types of pump being used, with the result that the chances of making an error go up. So for example, the another human factor that could come into it is fatigue. Now, if the nurse was doing a double shift because there's a shortage of staff, and the shortage of staff is there because the hospital has not been paying their staff, then it is very easy to blame the front end person who's at the 12th or 13th or 14th hour of their shift and working constantly, forgetting the fact that they are having to do double shifts because most people are going off sick, because the culture is of a blame culture, or the compensation is not being adequately done. So when we talk of human factors, you also have to take in the broader picture of what led to those human errors. So we've already talked a lot about, medication errors and the rate of errors, but the only point I want to focus on this slide is the second point, which talks about the risk of medication errors is increased to 12.7% for each interruption. And the risk of a human error is doubled with, harmful error is doubled with just 4 interruptions. Now, the reason I'm showing this slide and focusing on this point is that when nurses are administering medications, it is very common for doctors to just come in and talk to them about some other patient, or some other nurse to come in and talk to them about some other patient, or because they are going on a tea break to hand over their own patients. And actually, statistics have shown that in a drug round, if a nurse is disturbed while doing a drug round, her chances of making an error go up phenomenally. And that is why in the NHS, when a nurse is doing a drug round, she actually wears a jacket, a bright colored orange jacket, which says very clearly, do not disturb me, I'm on a drug round. And she will not talk to you, or he will not talk to you. So now coming back to the human actors and the factors that come into play, in cognitive factors, it can be fatigue. I've talked about doing extra shifts. It can be distractions. We've just talked about those. It can be workload and time pressures. If we are expecting too much to be done, instead of maintaining a 1:5 or a 1:6, which is a safe nurse to patient ratio, we are expecting a 1:9 or a 1:10 ratio, then errors will happen. Memory lapses can happen with anybody who's fatigued and working too much. Similarly, communication factors, we already heard about factor in which, because the patient was not educated, monitoring was not done. Poor handover, not using the right technique to hand over, illegible handwriting. I mean, doctors' handwriting is a joke all over the world. There are numerous memes about it all over the social media. Verbal orders, not having a proper policy of read back, write back whenever verbal orders are being given, defining situations in which verbal orders are being given. I shouldn't be giving verbal orders only because I'm sitting having my cup of tea and I can't be bothered to come up and prescribe the drug. So therefore, that's also very important. Language barriers can also result in failure in communication and increased chances of error. Now, environmental factors are very important. Noises, distractions, are we adequately staffed? Do we have the right equipment to deliver that sort of care? If I have set up a chemotherapy unit and I'm delivering chemotherapy, do I have the rightly trained nurses? Do I have the right environment to deliver chemotherapy? Do I have the right infusion pumps to deliver chemotherapy? One of the speakers talked about smart infusion pumps, just for people, so that people know. Smart infusion pumps are the new thing. They actually define for each drug what is the maximum dose delivery. So even if there is a human error, then you are prevented from an error, because the pump does not let you program 300 ml if the maximum dose is 45 ml per hour. So these are smart infusion pumps. These are the way forward. You have to program them for each drug. And this ability to be able to program things so that human errors do not happen is called human factors engineering. And that's a whole new field in itself. But this is just one example of what human factors engineering is. Then similar packaging or labeling, as pointed out by Dr. Mr. Saqib Aziz, about this ringer lactate and the drips having the same. There's a lot of concept of lookalike, sound-alike medications, and a lot of strategies that we take around them when there are lookalike, sound-alike medications, such as Stallman, Lattring, and things like that, which is very important. Inadequate staffing, system organizational failure, training, supervision, not having the right technology. We've already discussed all of these things in the coming thing. Then individual factors are also important. Sometimes there's a poor culture, there's poor teamwork, there's complacency. So yes, when there is complacency, when there is negligence, we should hold people accountable. That's why we say you should have a just culture, not a blame-free culture. The new word is just culture. If a person is at fault, it's a human error that has happened because of a person's negligence despite being trained, then yes, they should be held accountable. Then there are patient factors which can result in errors in medications, which is too many medications, as was discussed in one of the initial presentations, that polypharmacy is one of the leading causes of medication errors. And that's why every encounter we should do a medication reconciliation and ask the question which drugs need to be continued and which can be stopped. So in the end, I would like to talk about some strategies that we can use to reduce human-related errors. Double check systems, medications. So most organizations now have a list of high alert medications, and for high alert medications, you have to administer them through a double check system. Then have clear labeling and tall man lettering. What tall man lettering means is that for look-alike, sound-alike drugs, some of the letters are made into capital, which makes you realize that this is paracetamol and salicylic acid and things like that, so that you don't make errors while prescribing or labeling these drugs. Communication, appropriate handovers using appropriate tools such as SBAR. Adopting and developing a culture of safety in your organization so people feel relaxed and feel confident in reporting near misses and adverse events, so that they know that systems thinking will be put into place. As I've given you many examples, for example, where the infusion pump was wrongly programmed by a nurse, but the main cause behind it was we were having too many different types of infusion pumps. And hence, if we had one type of infusion pump, the chances of error would go down. Having a safer working environment and technology, so that use of technologies such as computerized prescriptions would take away the eligibility factor out of the prescriptions, would help you. Artificial intelligence will help you make decisions around drug interactions. And that is the way forward that people have adopted. And human factors engineering is the new thing. So for example, the smart infusion pump that I've already explained to you, which will actually prevent you from prescribing or programming the wrong infusion rate, because the pump itself has been programmed to know which drug has to be given at which rate. So these are human factors engineering, and these have to be done. As I said, that it is difficult for me in 15 minutes to go over the entire concept of human factors in medication errors. And what I've tried to do over here is to sensitize you that it is very easy to consider the person to blame is the person at the front end, but we should always be mindful and think about factors which led to that error, which are often system factors and not really related to that individual. And at that, I thank you again for listening to me, and thanks to the Punjab Healthcare Commission for organizing this event. Thank you all.
Thank you, sir. Thank you very much, Dr. Harun Hafiz Saab. I'm happy to inform you that at this point in time, we have around 100 plus people online listening to your talk and learning from your valuable experience. This includes all the tertiary care and leading hospitals of the Punjab, and the participants are clinicians, pharmacists, nursing officers, and quality assurance managers. So our the next talk and the next topic is pharmacovigilance and medication safety. Basically, this topic will be discussed by Dr. Sayyid Zia Hasnain, who's Additional Director, Drug Regulatory Authority of Pakistan, and head of the Punjab office of DRAP at Lahore. He's PhD in his subject and has been working with DRAP for quite some time. And Dr. Zia Sahab will talk about the pharmaceutical regulatory framework. And basically, pharmacovigilance focuses on identification of medication errors, reporting medication errors, taking corrective actions, and ultimately ensuring patient safety. And this will be sort of in detail discussed by Dr. Zia Hasnain sir. Over to you, sir. Thank you.
Thank you very much for providing me the opportunity to discuss on this very important topic regarding medication safety and how to report these adverse events to pharmacovigilance framework. Pharmacovigilance is being run by our Division of Pharmacy Services and DRAP. And this is the organogram. This is the director, then additional director, and officers who are monitoring who are working on the pharmacovigilance. The patient safety and medication safety, this is the definitions already discussed. So the framework of organized activities that creates culture, processes, procedures, behaviors, technologies, and environment in healthcare that consistently and sustainably lower the risks, reduce the occurrence of avoidable harms, and make errors less likely and reduce the impact of harm. Pharmacovigilance is the science and activity related to the detection, assessment, understanding, and prevention of adverse effects or any other therapeutic goods related problems. It has various factors like the detection of the problem, then its reporting, proper reporting, assessments, understanding, and then the various measures that how can we prevent these problems in future. In draft, there are various legislations have been done time to time regarding the patient medication safety. These are biostudy rules in 2017 are notified, then drugs licensing, registering and advertising rules 1976. These rules control the various aspects of the drug manufacturing, registration, and their advertisements. Then ethical marketing to healthcare professionals rules 2021, pharmacovigilance rules 2022, and the drug research rule 1978. This is the chronological pharmacovigilance, the working which was done since 1994. The DRAP and the then Ministry of Health, Drug Control Administration, they worked time to time. In 94, activities of pharmacovigilance were started and application was submitted to WHO headquarters for associate membership. Then in 2012, promulgation of the DRAP Act, Division of Pharmacy Services was given the mandate of pharmacovigilance. Then in 2017, establishment of Pakistan National Pharmacovigilance Center under the Division of Pharmacy Services. Then in May 2018, establishment of Provincial Pharmacovigilance Centers of Punjab at Lahore. And then in November 2018, Pakistan became 134th full member of WHO PIDM, the International Drug Monitoring Program of WHO. In October 2019, Pakistan National Pharmacovigilance Guidelines were issued. And then in 2019, notification of regional pharmacovigilance centers at ICT, and then the collaboration with the WHO UMC-based e-reporting module was launched. Then DRAP launched a medication safety mobile application for the reporting of adverse drug reactions in November 2020. And in March 2021, Federal Expanded Program for Immunization notified as Regional Center for AEFI, which are the reportings for regarding the after the immunization, the adverse event reporting system. Now, other drug-related problems, as already discussed, the medication errors, substandard and falsified medicines, lack of efficacy of medicine, misuse of abuse of medicines, as already discussed a lot, interaction between the medicines and off-label use, as already discussed by the various speakers. On the other hand, as the DRAP is regulating various therapeutic goods, including the allopathic products, which were already regulated by the Drug Control Administration prior to the DRAP Act 2012, then now alternative medicines, health and OTC products are being regulated. And biological products, there is a separate division for biological products. So it's very significant part of the allopathic products, biologicals, vaccines, and other blood products, and then medical devices. So DRAP has pharmacovigilance activities at DRAP, full member of the WHO program for international drug monitoring since 2018 and has established the procedures. Now, National Pharmacovigilance Center with 10 regional pharmacovigilance centers, as already told Sarasam, that at provincial levels, and then 3 administrative territories, 3 public health programs, then different means of reporting of ADRs, web-based, Vigi mobile app, as I already told you, then yellow reporting form, email, and subscription of the national database, that is VigiFlow, since 2018. So dedicated legislation of regarding pharmacovigilance was done in 2022, notified by SRO 540, then regular issuance of safety alerts, advisories, and product recalls time to time when there is a drug reported substandard by our provincial governments and even the Central Drug Laboratory. Then there is dedicated pharmacovigilance guidelines for market authorization holders, patients, and healthcare professionals and public health programs. So DRAP at the various level, from industry to from the market authorization holder who has the registrations of the products, then the patients and the healthcare professionals and the public health programmers. These are the various stakeholders which deals with the medicines. So DRAP has interaction with all these with regard to the pharmacovigilance. Then regular submission of pharmacovigilance data is being maintained at DRAP by the various stakeholders. This is the organogram, as already told you, from 2018 to 2025. These are the various steps taken by DRAP, and now, alhamdulillah, all the stakeholders which deal with the medicines, they are in loop with regard to the pharmacovigilance with the DRAP, and various reporting systems have already been devised. And now it is the ethical and moral obligations and duties that the stakeholders, they report without any fear. They report the adverse events on those various systems, so that that data may be collected at the DRAP headquarters and analyzed, assessed, and the future preventions regarding any medication safety error or any medication errors or any medication safety aspects which are creating the problems can be discussed. The pharmacovigilance process is the collective of adverse drug reactions, then assessment of adverse drug reactions, adverse events, signal detection and management, benefit risk evaluations, risk minimum measures, and risk communications are being done at DRAP. These are the various aspects. Who can report and how? Now, as I already told you, that the various stakeholders, they can report the adverse events. Patient and relative of patients, they can report through telephone, via email, e-reporting system, and Vigi mobile application. This mobile application can be downloaded from the DRAP website. There is a QR code, and it can be downloaded on Android mobile or iOS mobile. So from that mobile application, patient, relative of patient can report the adverse events. Healthcare professional, there is a mailing address, then there is e-reporting system, email, and Vigi mobile app as well. Similarly, the registration holders, MH holders, the industry, their e-report, E2B files through emails. Then provincial pharmacovigilance centers, there is a VigiFlow link has been given. जो उपसाला की जो है वहां से उनको लिंक दिया गया है, वो that central link has been shared to the various hospitals as well, and they can report the adverse events or any safety related events with regard to drug or medication errors through this VigiFlow, and that will be transferred to the database of DRAP, and that database, then from that database those events can be analyzed. Then hospitals, VigiFlow to the provincial centers. So there is a link from VigiFlow to the provincial center, and from provincial center that data will be transferred to the DRAP headquarters. So these are the various measures already taken, and with regard to the implementation of pharmacovigilance by DRAP. This is the mailing address of our national program for vigilance. In charge, National Program Pharmacovigilance Center, Division of Pharmacy Services, DRAP, headquarters, Islamabad. There is email and then telephone number. These are the various legislation I already told you, DRAP Act and Pharmacovigilance Rules 2022, and other legislations already discussed. With regard to antimicrobial resistance, DRAP is now implementing the 2D barcode system on the products. And the regular compilation of import data of antimicrobials will be compiled in that database. Issuance of advisories, time to time sale of antimicrobials on prescription of registered medical practitioners, implementation of drug sale rules, assurance of qualified person. As you know that in drug sale rules, there is a provision that there must be a sale purchase record for the psychotropic and narcotic products, and the antibiotics and other life-saving drugs cannot be sold without the prescription of registered medical practitioner. So these implementations are required. Then assurance of qualified personnel on the pharmacies, so that the layman cannot dispense the medicines which can cause a serious medication error. Then maintenance of prescription and sale records, as I already told you, the issuance of guidance documents, responsible use of antimicrobials. और वो जो already बात हुई कि the prescription should not be refilled and not be reused. Dr. Huma already told. Then core element of antimicrobial stewardship programs. These are already being initiated by DRAP, and a pilot program regarding the 2D barcode system has been done at Islamabad, and it will be replicated at the provincial levels as well. And by this, we have the whole data that how much raw material of the antimicrobials, antibiotics is being imported, and then it will be linked to the distributors, and finally it will be linked to the pharmacies. And we will have an eye on the antibiotics that, and even the other products, that how much raw material is imported and how much raw material is present in a particular manufacturer with the particular manufacturer, and how much product is manufactured from that raw material, and how much is in the warehouse of the main industry, and how much it is present at the distributor level. So whole chain is now being regulated by DRAP, and it will be on the database and dashboard of the DRAP. So in this way, we can control the whole chain in future, inshallah. A positive medication safety culture depends on active and collaborative relationship between all stakeholders. So I already told Sarasam that Asam Rao Sahab, that now the system is there, various reporting systems already there. Now it is requested to all the stakeholders that they should immediately report any medication error or adverse event on various 4 or 5 tools, so that we may have that data of the medication errors for further necessitation at the level of DRAP. Thank you very much.
Thank you, Dr. Zia Hasnain Sahab. Thank you very much for elaborating the role of DRAP and pharmacovigilance in ensuring medication safety and ultimately patient safety. Ladies and gentlemen, before I thank you all for being with us on this webinar, जो discussions हुई और जो points highlight हुए, basically उसमें regulators का role, including drug regulatory authority, including PMDC, healthcare commissions, definitely in their own jurisdiction. और उसके साथ साथ educationist or educational institution का role in training the experts, healthcare professionals in judicious use, as well as in enhancing their knowledge and skill in prescribing medications. Similarly, there was a recommendation to control self-medication by the people themselves through creating awareness and also through regulatory enforcement, which basically requires defining and introducing, notifying OTC drugs sort of list. There was a recommendation from participants and speakers having a national formulary as well as pediatric formulary for ensuring patient safety, or definitely ultimately for ensuring medication safety. We need to have a culture of reporting identification, reporting analysis, and taking corrective action, what went wrong, where in case of medication errors. So before I request the CEO Sahab for concluding, and to thank you all for joining us, and thank you, the expert speakers, there are a couple of questions from the participants, which I think would be pertinent to respond. पहला क्वेश्चन सर हारून हफीज साहब आपसे किसी ने पूछा है what is the responsibility of hospital with regard to volunteers and medication errors occurring as a result of their work? Does the hospital have a responsibility if a volunteer start practicing privately? So I know कि इसमें it's addressed to you, आपको directly इन्होंने पूछा है जी.
Happy to take this question. I think in any institution, whether educational or healthcare or any industry, if you have a volunteer, the volunteer, when they join, need to have a very definite sort of description of what they are allowed to do and what they are not allowed to do. And the volunteer needs to undergo training and orientation before they are allowed to be at the workplace. If all of those steps have taken, then I think the question of the volunteer doing something which they were not allowed to do should not come in. If the volunteer is an observer doctor who was allowed to prescribe, then the hospital has to take full responsibility if there was a medication error related to a prescription done by that doctor. But as I said, the key thing is that when a volunteer comes, you need to have a very clear orientation program for your volunteers, and you also need to make sure that you have a document defining very clearly for the volunteer what they can do and what they cannot do in the workplace where they are.
Thank you, sir. Thank you very much. The second part of the same question is what is the responsibility if a volunteer starts practicing privately? So I think this comes into the ambit of Healthcare Commission as regulator. He or she will definitely be, if being unqualified to practice privately, will be dealt as a quack, and appropriate legal action is liable to be taken against such persons. Second question is, maybe Dr. Asam would be able to respond it. Is there a mechanism for consumers to track and trace to verify original manufacturing of medicine they buy for consumption, as it is being practiced by FBR in cement industry and tobacco industry?
Sir, thank you very much. At this point of time, I would say there is a 2D barcode system that is in place, but not fully implemented. The last data that I had was around 200 plus firms out of 600 plus. They had implemented this track and trace system, and once you scan it and you get the basic information. Then there is another system with the web that is called DRIS system. So there are two parallel systems they are running at this present moment. But there was and there is some, I would say, glitch or some issue with reference to legal complications that it has not been fully implemented. The Supreme Court of Pakistan, once they said, talk to all stakeholders and then come up with the solution and the timelines for implementation. And I think that has been done. And now the draft is fully geared to implement it on all the firms. And present government is fully aware about that. And I have seen so many talks from our federal minister that he wants to do it as early as possible. So we hope that it is implemented across all of the pharmaceutical firms.
Thank you, sir. Thank you very much. And since there is no question from the participants, it's my humble duty to thank all the participants who have joined us on various platforms in the PSC YouTube channel or uske alawa jitne bhi social media platform or Zoom link pe. Thank you all for being with us for such a long time. और इसके साथ ही I would request the CEO of Punjab Healthcare Commission, Dr. Saqib Aziz Saab, to thank to the expert speakers and to conclude the webinar. Please, sir.
Thank you very much, Ji. Or I especially thank our distinguished guests who are with us and still with us. And they shared their valuable inputs, starting from Khalid's Dr. Professor Gondi Saab and Khalid Masood, VC Saab, Dr. Asim Rauf Saab, and Dr. Harun Hafiz Saab, and Dr. Syed Zia Hassan Saab for sharing their very valuable inputs and suggestions. One thing is clear, and that thing is that the issue is not simple. It is multi-layered and multi-faceted. It has generated a lot of challenges, and we have tried to address or at least flag these challenges, whether it is the issue of relating to DRAP as a regulatory body or Punjab Healthcare Commission as a regulatory body, or role of HCs and here healthcare professionals, or the culture of non-reporting or culture of blame game, how to change that culture. And very interesting suggestions were also made. And I wonder that where to start and what is the first step in this direction, that how we can control and address or make the whole system more safer for a patient. The recommendation by Dr. Gondal Saab to include some aspects in undergrad or postgrad is very I really appreciate that suggestion. Similarly, the issue of having a national formulary or national pediatric formulary is also important. Similarly, the issue of having a proper clinical governance culture and culture of leadership and culture of management, and how to create and how to bring forth this culture and how to engage all stakeholders, I think it's not easy and poses a lot of challenge for all of us. And that's why the title of today's this week was that it is not the responsibility of 1% or one stakeholders. Perhaps it is the responsibility of all of us to work in tandem, and perhaps then we can overcome or resolve some of the issues. I'm thankful again for all the people who joined us, and especially those who have joined online, and my team, Dr. Mushtaq and his team, for arranging this webinar. Punjab Healthcare Commission has earlier also had arranged such seminars and webinars, and in future also we will inshallah conduct such events for patient safety and to promote safety culture. Thank you very much.
Thank you, sir. Thank you very much. Thank you all.
Allah Hafiz. Assalamu alaikum. Thank you, everybody.
Thank you.
Sir, आपने कुछ कहना तो नहीं है? I thought you were mute.
I really enjoyed the talk of everybody. I just wanted to thank you for arranging a seminar on such a wonderful aspect, which was very much needed.
Thank you, sir. Thank you. Thank you very much. Thank all the participants who were with us online for 2 hours and some more time. Thank you, ICT team from PHC or yes, from research and publication also. Thank you very much. Thank you. Thank you all, sir. Thank you very much. Thank you.